Good morning, everyone. Today we will discuss multiple scenarios in the emergency table. So, shall I start now?
Yes, please.
Oh, that's great. Thank you. You are the on-call doctor for urology, and you got a referral from the medical team saying that they are worried about a diabetic patient who is admitted mainly with fever, and their main concern is a scrotal swelling, which they think is looking really abnormal. So, what are your thoughts, and how would you want to proceed?
So I will go to see this patient as a matter of urgency, since my concern is it could be a Fourniers Gangrene. So I will go to review the patient. I will check his blood test, any urine test, whether he is an antibiotic or not. I will check his observation before I see the patient. And then I will see the patient. I will take a focus history, asking about the onset of the swelling, the pain, is there any, whether the patient have noticed any abnormal discoloration or abnormal smell from the area. Then I will take a brief history also about his baseline lower urinary tract symptoms, any associated comorbidities apart from the diabetes, his medication and allergy history, past surgical history, social history, especially if there is excess alcohol intake, any previous urethral manipulation, any previous catheterization or surgery, any recent trauma to the area, which may be a cause as well. And then after that, I will examine the patient, check his OBS, especially the fever, blood pressure, pulse, and then I will examine the abdomen, looking for any palpable swelling, which could be the stent in the bladder. I'll examine the groin, and then I'll examine the penis, and I'll examine the scrotum anteriorly and from the posterior aspect as well, looking for the swelling, any abnormal discoloration, if there's a cellulitis, whether to see the extent of the cellulitis, and I will mark that to assess the progress. I'll examine the perineum as well, and I will do a DRE, since sometimes the focus of the infection may be starting from the perineum. So this is my initial approach to the patient.
Okay, well done. So he is a 64-year-old gentleman who has diabetes, which is uncontrolled. 1 week ago he had a circumcision for a tight phimosis. The wound is healing well, but his scrotum is swollen, and there is a necrotic patch on the dependent part of the scrotum. He is not on a catheter. He denies any urinary symptoms. No previous history of any anorectal pathologies. What is your diagnosis now?
So my diagnosis is Fourniers Gangrene, which is a necrotizing fasciitis involving the scrotal skin and subcutaneous tissue. This is a urological emergency, since it is associated with a high mortality of about 30%. So for this patient, I will make sure that he is hemodynamically stable. If he's hypotensive, then I will start some IV fluid for the patient. I will start antibiotic immediately, and I will manage the patient according to the sepsis 6. So I will start the patient on a high flow oxygen, insert a wide bore cannula, take a blood for cultural sensitivity, aerobic and anaerobic. Also take a blood to check the baseline renal function, follow blood count, clotting profile, and group and safe as well. After that, I will start the patient on the IV fluid, IV antibiotic according to the trust guideline, and I will insert a urethral catheter as well for the patient, and send a sample for culture and sensitivity according to the sepsis 6 protocol. Also for this patient, I will involve my colleague in the HDU ITU team because most likely this patient need a care at the HDU. I'll explain to the patient the nature of this serious infection, and I will contact the emergency theater and arrange for the patient to be taken to theater as soon as possible. In my consent, I'll consent the patient about the procedure, about the need for an urgent debridement and further debridement depending on the progress of the condition. The patient may need some plastic surgery in the form of skin graft if there is a big skin defect. I will inform the patient and the family about the high mortality, which is around 25 to 30%. I will inform the patient about the need to divert the urine via urethral catheter or suprapubic tube, depending on the extent of the lesion, and also the low possibility of the need for diversion of the bowel as well. So these are the main things that I will arrange.
Okay. So what are the bacteria involved in Fourniers gangrene?
So Fournier gangrene is a synergistic infection between aerobic and anaerobic bacteria. The aerobic one mainly are gram-negative, like E. coli, Pseudomonas, and Klebsiella, while the anaerobic, it could be Bacteroid, Clostridium, and other bacteria.
Okay. What is the antibiotic pattern followed in your for Fourniers gangrene followed in your trust?
So in my trust, we usually start the patient on gentamicin, 5 milligram per kg, coamoxiclav, 1.2 gram 3 times daily, and metronidazole, 500 milligram IV 3 times daily.
Okay, well done. And how does the Fourniers gangrene spread?
It's mainly spread in the subcutaneous tissue in the fascia, therefore it's called necrotizing fasciitis, and it will cause a destruction of the tissue and thrombosis of the blood vessels, and then it will spread under the skin. After that, it will show itself as a gangrenous patch on the skin.
Okay, so I would slightly add on some keywords for that answer. So we can say that the necrotizing fasciitis, as you said, will spread through the facial planes, and it is limited by the Buck's fascia in the penis, Dartos fascia in the scrotum,
Dartos fascia in the scrotum, Colles fascia in the perineum, and Scarpa's fascia in the abdominal wall.
Okay. Is there a chance that the testis can get involved in Fourniers gangrene?
Quite unlikely, because the blood supply of the testis is coming from the testicular arteries, which are usually not involved in this process. So most of the time, the testes are preserved.
Okay. When you take the consent, will you take the consent for orchidectomy?
Yes, because I don't know the extent of the infection. So for this patient, I will consent him for possible orchidectomy as well.
Okay, well done. And do you know about any scoring system for Fourniers gangrene?
Yes, I'm aware of a scoring system for Fournier gangrene, which take into consideration some clinical information and some laboratory values, like the white cell count and other things. But I can't recall the details of the scoring system.
Okay, even though it is not widely practiced, for exam purposes, we have to know about the Fourniers gangrene severity index. As you said, there is multiple parameters for that. The original author stated that when the score is more than 9, the risk of mortality is around 75%. And when the score is less than or equal to 9, the risk of survival is around 78%.
Yeah.
And there is also another scoring system called LRINEC, LRINEC, not specifically for Fourniers gangrene, but for the diagnosis of necrotizing fasciitis or necrotizing soft tissue infection. It is called the laboratory risk indicator for necrotizing fasciitis.
Yes.
It is also it was developed to distinguish between the necrotizing fasciitis from cellulitis or abscess. Again, not widely practiced, but it is classified into three groups like low risk, medium risk, and high risk. So definitely, if you can say about Fourniers Gangrene Severity Index, even though you need not tell about the different components because there is a lot of components, but the number that we had to remember is 9.
Yeah.
So you said that you said about the split skin graft. Will you do it during the procedure, or how's the approach of reconstruction?
Usually, we do the initial debridement, and then within 24 hours to 48 hours, we bring the patient for a second debridement. And then when we will assess the amount of skin loss and the healing of the area, when we start seeing active granulation tissue, and this is the time to involve the plastic surgeon to apply the skin graft. So usually it is not early. We need to control the infection first, have a sign of active of healthy granulation tissue, and then we can involve the plastic surgeon.
Okay. Is there any role for VAC dressing, vacuum assisted closure system?
Yeah, this is one of there are a few technique recommended during the debridement of the wound, include an aggressive debridement, especially in the first time, and also irrigation of the wound using hydrogen peroxide or povidone iodine. And then after that, apply the dressing. And some of the center they are using the vacuum dressing, which in the studies associated with a better healing. However, in my practice, we are just using the usual classic dressing.
Okay. And is there any role for imaging before taking the patient to theater?
Yes, it all depends on the stability of the patient and about the suspicion of how deep the spread of the infection. So I would say for a patient with a small patch in the scrotum, usually imaging will not change our treatment plan, but for a patient with extensive scrotal and perineal gangrene, then and if we suspect that there may be a deeper pathology, so for this patient we can arrange for a CT scan, which will show us the extent of the infection and necrotic process and the gas. For the equivocal infection, sometime we don't know exactly whether this is an early Fournier gangrene or epidermolysis. Ultrasound may be useful as well by showing the gas under the skin.
Okay, well done. I think we have discussed all about Fourniers gangrene. Shall we move on to the next one?
Yes, please.
Okay. So in this scenario, you are called by the A&E team for a 42-year-old lady presenting with fever, chills, rigor, left loin pain. She is in A&E, and because of the left loin pain, the A&E registrar is calling you to get your advice. What is your approach?
So I will see this patient in the emergency department as a matter of urgency, and I will take a focused history. I will make sure that she is comfortable at first, she is resuscitated, and her vital signs are stable. And then I'll take a focus history about any. She has a pain, loin pain as well.
Yeah, left loin pain, fever, chills, rigor, 42-year-old lady.
Yeah, thank you. So I will ask about the onset of the pain, for how many days, severity of the pain, and I will ask also about the onset of fever and rigor at home, any associated nausea and vomiting. I will ask about her any dysuria or hematuria, I'll ask about the previous similar episode, whether the patient is known to have any stones before or not, whether the patient is known to have a recurrent urinary tract infection before. I will ask also about the past medical history, looking for any risk factor for infection, including diabetes, immune suppression, the use of certain medication, and also I'll ask about any previous surgical history and social history. I'll examine the patient, checking her vital signs. I'll examine the abdomen, looking for any swelling or tenderness in the loin. I will check that there is no distended bladder, and I will have a look on the genitalia as well for this patient. Yeah.
Okay. So this lady is previously known to have stone disease on the left side. She had one session of ESWL but then did not attend for further sessions. Currently, she is conscious oriented, talking well, talking in full sentences. Her temperature is 39 with a heart rate of 116, blood pressure 90/60. On examinations, she is tender over the left flank. So what is your protocol? What is the diagnosis, and what is the protocol that you are going to follow for her?
So for this patient, because of the previous stone history, I would suspect that she may have an obstructing pyelonephritis because of the combination of infection and history of previous stones. So for this patient, it is regarded as a case of sepsis. I will apply the bundle 6 sepsis, sepsis 6 bundle. So for this patient, I will start her with on high flow oxygen, 15 liter per minute via face mask. I will insert a wide bone IV cannula. I will take a blood for culture, aerobic and anaerobic, and also for the renal function, coagulation profile, full blood count, group save in case we need it, lactate and the glucose. And I will start a broad spectrum antibiotic and IV fluid, and I will insert a catheter for the patient and send a sample for dipstick and cultural sensitivity. All this should be done within 1 hour. And then after that, I will arrange for the patient to have an urgent imaging.
Okay. Which antibiotic do you start in your trust protocol for this presentation?
The use of protocol in my trust is to give a shot of gentamicin, stat dose of gentamicin, 5 milligram per kg, and then we start the patient on a regular comoxiclav 1.2 gram IV 3 times daily.
Okay. What is Hartford's regime?
I'm not sure.
Yeah, so that is the most commonly used protocol for the starting of gentamicin and the further continuation of gentamicin. So usually we give the first dose and then followed by the second dose after 24 hours. Then we have to check the gentamicin level. This should be monitored. This should be guided by the renal function tests as well. So most of the trust follows the Hartford's regime. And then moving forward, you are suspecting a stone obstruction, isn't it? So
yeah.
What is your imaging of choice?
My imaging of choice is to have an urgent, I will check the kidney function of the patient. If the kidney function are fine, then I will arrange for the patient to have a native CT-KUB and then a contrasted one as well.
Okay. So your radiology department arranged for an urgent CT-KUB. It shows a 6 millimeter calculus in the left PUJ showing moderate hydronephrosis. There is perinephric fat stranding but no collection of abscess. She clinically improved after resuscitation and the antibiotic, but her temperature is still a bit higher at 39.5. She is still shivering. Her blood shows that her creatinine is 148. Her white cell count is 16. How do you want to proceed from here?
I will arrange for this patient to have an urgent decompression of the urinary tract in order to treat her sepsis, and I will liaise with my colleague in the intervention radiology to arrange for the patient to have an urgent percutaneous nephrostomy insertion. I will contact a microbiology colleague to chase the result of any culture and change antibiotic accordingly. And I will involve my HDU team colleague as well early in case further deterioration and she need to go to HDU either before or after the percutaneous nephrostomy.
Okay, unfortunately it is a weekend and there is no interventional radiologist to do the nephrostomy insertion. Any other options for her?
The other option is to take the patient under general anesthesia to insert a stent, but the nephrostomy is preferred over a stent insertion since it is done under local anesthesia. The chance of success in getting access into the pelvic rhesus system is higher with the nephrostomy than with the stent. Also, the pressure reduction, intra-renal pressure reduction after nephrostomy is better than the stent. If there is a thick inspissated pulse in the kidney, then the nephrostomy will drain that in a better way. So for all these reasons, I would prefer to have a nephrostomy. However, if there is no nephrostomy service and the patient is unstable to be transferred to another hospital, then I will consent the patient and the family about the need for an urgent GI cystoscopy retrograde study and stent insertion.
Okay. So you consented and marked the patient for a left ureteric stent insertion. Can you take me through the procedure, please?
So for this patient, the procedure will be done in the emergency theater. So I will make sure that I will go to theater myself, check if any of the nursing staff in the emergency theater have some urologic experience. I will check that the table is X-ray permeable. I will make sure that I have all the instrument ready, including the cystoscopy, the retrograde ureteric catheter, sensor guide wire, the stent, and I will keep in mind that in case there is difficulty in inserting the stent, I may need to do also a semi-rigid ureteroscopy, and we use the pneumatic lithotripsy in order to fragment the stone and push the stent.
Okay. Okay. So, if you are able to pass the guide wire beyond the stone, will you do a primary ureteroscopy in this case?
No, in this case, I will try to do the minimum procedure, the shortest procedure with a very low, I will use a very low irrigation pressure as well. I will do the cystoscopy for this lady, and then I will put a ureteric catheter. If my ureteric catheter bypass the stone, I will take some sample of the urine for culture sensitivity, and try to aspirate some of the, especially if there is a pulse coming, try to aspirate some of it, and then after that I will pass the sensor guide wire above the stone and insert the stent and finish the procedure as soon as possible, and I will leave a urethral catheter at the end, and then I will bring the patient for a secondary procedure later on.
Okay, well done. So how do you monitor the patient postoperatively?
We monitor the patient postoperatively by checking her observation signs and also by a blood test. So I will check, we use the MUSE, which is modified early warning sign scoring system in the hospital. So I will check her MUSE. I will repeat her blood test, including an inflammatory marker and full blood count, kidney function. I will chase her cultures and assess her clinical progression.
Okay. In the exams, it is also nice to involve say that you will involve or inform the outreach team in case if the patient deteriorates afterwards.
Yeah, definitely. I will keep a threshold. If there is any deterioration, then the patient will be transferred to HDU.
Brilliant. Thank you. Shall we go for another scenario?
Yes, please. One last thing, please, if I can ask about,
Sure.
because there is some change in the definition of sepsis with this sepsis 3 consensus. Are we using the same terms like
Oh,
systemic inflammatory response, sepsis, septic shock, severe sepsis?
I know. So I should have discussed on that one as well. So now there is we are not guided by the SIRS modes or sepsis pathways. These definitions no longer hold true as well for the diagnosis and treatment of sepsis. We can use two types of scores, either SOFA score, but SOFA score is extensive and is designed to used in a ICU setup
Yeah,
for identifying patients with high risk of sepsis in outside the ICU. You can use the Q-SOFA score.
yeah,
So the Q-SOFA score has only three components, where it is one is altered mental status, and then a respiratory rate of more than 22 and a systolic blood pressure less than 100.
yeah.
So
If there is any two or more, then it suggests a high risk.
exactly, and if but they say that even if the score is 0, if clinically if you still suspect sepsis, the advice is to continue the monitor, evaluate, and follow the patient up with continuous Q-SOFA score. So you can tell about the SOFA score and Q-SOFA score if that question is asked.
Yeah.
So for the next scenario, you are called into the emergency department for the evaluation of a 17-year-old boy who developed acute onset of left testicular pain of 4 hours duration. How do you want to proceed?
So this is a urological emergency, so I'll go to review the patient myself, since my concern is a possibility of testicular torsion. I will make sure that the patient is comfortable with adequate pain control, and then I will take from the patient a brief history, asking about the onset of the pain, whether acute or gradual, over how many days, or sorry, you mentioned it is at 4 hours. I will ask about any radiation of the pain, whether localizing the testis or radiating to the lower abdomen, any associated nausea and vomiting, if there is any fever or dysuria, urethral discharge, which is suggestive of an infection. I will ask about his sexual history, any unprotected sexual intercourse recently, any history of trauma or fall, any previous episode of similar pain, and any previous surgery in the testis. I will ask about his past medical history, any comorbidities, drugs, and allergy, and I'll ask about his previous surgical and social history. In examination, I'll examine the abdomen, looking for any tenderness. I'll examine both the groin, looking for any hernia or palpable mass, and then I will examine the normal testis first, and then I'll examine the left testis, looking by inspection into the scrotum, whether there is any significant swelling, any redness in the scrotum, whether the testis is high riding by inspection, and then by palpation, looking for any for the temperature of the scrotum, and also for the tenderness. Whether the tenderness is mainly located over the testis or over the epididymis. Whether I can palpate the epididymis anteriorly, which indicate a torsion, and after that. I will assist I will counsel the patient accordingly.
Okay, so he is 17-year-old. He is sexually active. He has some dysuria. The team at A&E has done a dipstick examination which shows leukocyte 3 plus, otherwise normal. When you examine, there is diffuse tenderness, and okay. So how do you proceed from here?
So, although the urine dipstick showing some leukocyte, but since torsion cannot be excluded, and the patient in the high risk group and the high risk age group, which is between 12 to 18, and within 4 hours, I will proceed to surgical exploration rather than waiting for further confirmation with secretal Doppler ultrasound, since the time is very important to save the testis. So for this patient, I will ask whether he's fasting or not. Even if he is not fasting, I will inform my emergency theater team that this patient need to go immediately to theater, and I will consent him accordingly.
Okay. So how do you, the patient is consented, marked, anesthetized, checklist done, and is on the table, supine position. So can you take me through the procedure, please?
So for this patient, I will start by doing a midline raphe incision. I will deliver the left testis and to see whether there is a torsion or not. If there is a torsion, I'll detwist the testis and then assess for the viability and changing color. If the color will return back to pink normal color within short time, then I will do orchidopixy, 3-point orchidopixy on that side, and I will do also the contralateral testis, explore the contralateral testis through the same incision and do a 3-point orchidopixy using 3O proline. If the testis is still purple or dusky, I will ask the anesthetist to give 100% oxygen, and I will wrap the testis in a swab soaked with warm saline and wait for 15 to 20 minutes for change color. During this time, I will do the contralateral fixation. If the testis after 20 minutes still quite dusky purple, and then I will consider orchidectomy for this patient. If there is no torsion, then I will not do any orchidopixy or fixation. If I see any hydatid of Gangrene, I will exercise to avoid presentation later with the twisted hydatid of Gangrene.
Okay. Well done.
After that, usually the patient, if he's fine postoperatively, he can be discharged on the same day. I will not consider prosthesis, testicular prosthesis insertion on the same setting, and I will arrange for the patient to have a follow-up in the clinic in a 3 months time.
Okay. And what is the risk of orchidectomy depending on the time of presentation?
So we know from previous studies that the chance of preserving the testis is about more than 95% if the patient presented within the 4 hours, and more than 90% if he presented within 6 hours. And then the chances start to decrease significantly after 6 hours, which is the golden time. And usually after 24 hours, the chance of saving the testis is around 5 to 10% only. So I still explore the patient even if he presented within 24 hours, but I will inform the patient and the family that there is a high chance of doing orchidectomy rather than orchidopixy.
Okay. And what are the long-term effects of orchidectomy?
So the long-term, the main concern of the patient and the family are the future fertility and hormone production. I can't comment on the future. I can't guarantee the future fertility even after a successful detorsion and orchidopixy. And for hormonal production, it may be affected later on if orchidectomy is done and the patient have only one testis. Okay.
So that's a good answer for the counseling, and also you can involve the answer that there are studies which says that the paternity in males with one testis appears to be normal. If it is like a partial atrophy, it can affect the spermatogenesis, but still we don't know there's no clear evidence whether it will affect the fertility later.
Yeah.
Okay, so we'll go for the next scenario, if it's all right.
Yes, please.
So in this scenario, you are in the elective theater. You just finished a TURP for a 74-year-old gentleman. It was a difficult procedure. The gland was very vascular. At the end of the procedure, the urine appeared to be clear. You put on a 3-way catheter. Patient was transferred to the recovery. You are about to receive the next patient. Then the recovery nurse came and informed you that the patient is in severe distress and he is in severe pain. So how do you approach this one?
So I need to go to see the patient myself in the recovery. I will inform my anesthetist not to send for the next patient until we see what's happening with the 2RP patient. So I'll go to review him in the recovery. I'll make sure that he is not in pain, and also by giving him a painkiller, and also he is resuscitated with stable OPS. So for this patient, I will check his blood pressure, pulse, temperature, and then I will examine him, mainly concentrating on examination of the abdomen, looking for any palpable bladder, and then I will check my catheter to see whether it is draining a clear urine or there is hematuria. If there is hematuria, I will increase the rate of the irrigation. If it is not draining, then I'll suspect that there may be a clot in the bladder. So I will do a gentle flushing by using a bladder syringe for the patient to see whether this helping or not.
Okay. So when you go there and the patient is in severe distress, you can see that the irrigation is not running; it is blocked. You suspect clot retention. So how do you manage the clot retention immediate post-op?
So for this patient, while I'm doing the bladder irrigation, I will ask my colleague or my registrar to arrange for urgent blood tests, including full blood count, renal function, clotting profile, and a glucose save of 4 units of blood. I will inform the anesthetist that this patient may need to return back to the theater. At some point, I will start by trying to do irrigation, bladder irrigation through the catheter. If it is not working, I will deflate the balloon, push the catheter a little bit inside, and then inflate the balloon again, and try to irrigate, try to remove the clot if it is possible. If it is still not working and the catheter completely blocked, then I will inform the patient that he needs to go back to the theater. I will consent him again with a new consent form for cystoscopy, clot evacuation, diathermy, plus minus open clot removal, plus minus packing of the prostatic fossa. I will make sure that his bloods are fine. If there is a drop in the hemoglobin, I will start transfusing the patient while he is taking back to theater. I will check his clotting profile as well. I will involve my anesthetist in the assessment, and I will involve the HDU team in case he need to go to HDU after the procedure. And I will have a chat with the patient family over the phone, explaining the situation as well.
Okay, well done. So you have comprehensively covered all the points. I would suggest to add one more point where you will say that you will involve one of your senior colleagues as well, because it is a difficult situation.
Yes,
it is
of course, yeah.
Going back to the theater once more. You might need a hand if you consider that it needs to be an open procedure. Yeah. All right. But for you, gentlemen, initially you did the bladder washout. Everything went fine. So you re-inflated the balloon, observe the urine for some time. The catheter is draining well now, but it is very high colored, and you can see a pulsatile type of bleeding from on the clear catheter. So
yeah.
What is your diagnosis now?
So in this case, this is a post-TURP bleeding. I will try to overinflate the balloon into 50 ml and apply some traction over the bladder neck. And I will apply the traction for about 30 minutes and then relieve it for 5 minutes to see whether there is a response. If the patient responds, then we'll just continue some intermittent tension on the catheter if needed, and close observation of his obs and irrigation. But if the bleeding persists, then I will take the patient back to theater.
Okay, because in your case the bleeding persisted, you informed the family, consented him, and involved the colleagues, involved the HDO, informed the anesthetist. The patient is going back to he's in the theater. Which position do you want to do the repeat procedure?
I'll start the repeat procedure by do the WHO checklist, giving the patient antibiotic, and then after that I will start with lithotomy position. I will go with the resectoscope directly for this patient. I will put the resectoscope, try to irrigate the clots out. Sometimes if the clots are a little bit big and sticky, I will use the loop of the resection to fragment the clot. I will use the Ehrlich evacuator and sometimes also the bladder syringe to try to get as much as possible of the clot to get a clear vision. And then I will try to do some hemostasis if there is an obvious bleeding coming. However, if I couldn't see any obvious bleeding, just a diffuse bleeding or the clots are quite sticky, I couldn't proceed with cystoscopy, then I will just change the position into supine position, do a Phoenix-steel incision, go directly to the bladder, open the bladder, remove the clots, and sometime after removal of the clot, we may be able to see some bleedings coming from the bladder neck, especially at 5 and 7 o'clock. So I will put some stitches there, which may help to control the bleeding. However, if the bleeding is still significant, diffuse bleeding, I couldn't find an obvious source for the bleeding, I will do packing of the prosthetic fossa by putting some swabs around the catheter, and I will take the thread of the swabs out through the closure of the bladder and through the abdominal wall, and I will keep the patient in HDU, and I will under antibiotic cover, and then I will bring the patient back to theater in 48 hours for assessment and removal of the packs.
Okay, well done. I would suggest to add a step in between where you put the stay sutures, open the bladder, inspect the cavity, evacuate the clots, and then inspect the prostatic cavity, put the stitches. Afterwards, if it is still bleeding, one of the options is to try a hemostatic agent like a Surgicel. Pack the prostatic cavity with Surgicel over the catheter and see if it is bleeding is controlled. If not, then go for the next step of gauze packaging, because gauze packaging definitely needs the patient to come back to the theater, isn't it?
Yeah. The surgeons still have the advantage that if the bleeding is stopped, then there is no need to bring the patient back again to theater.
Exactly. Yeah. So it is always better to go in that stepwise manner. But yes, sometimes if it is not controlled with Surgicel, then definitely we have no other choice but to involve our colleague and then pack it with gauzes and then come back for a second look later.
Yeah.
We'll go to the next scenario, which we nowadays are not seeing with the bipolar instruments, but still for the purpose of discussion, this was a training list. Your registrar is doing or getting trained in the TURP. Why the patient has got comorbidities, so the procedure is done under spinal anesthetic. While doing the procedure, two events are happening. One, the anesthetist is concerned about the bradycardia that's happening, and also the patient says that he can feel some tinkling on his face. Do you need to be concerned about this?
Yes, I need to be concerned, especially if it is a monopolar TURP, since this could be an early sign of TUR syndrome. So the TUR syndrome is a multifactorial syndrome, include a combination of fluid overload, delusional hyponatremia, and direct toxicity from the irrigating fluid, which is usually 1.5% glycine.
Okay. What are the clinical manifestations of TUR syndrome?
So the clinical manifestation usually it depends on the level of serum sodium. So at a level of a level above 130, usually the patient is asymptomatic. At the level of 120 to 130, the patient start to have some restlessness and confusion. Between 115 to 120, you will have also nausea and vomiting, and usually when it is less than 115, the patient start to have convulsions and becoming unconscious. So in TURP, usually I would prefer to do the patient under spinal anesthesia, so he'll be awake. The patient may start noticing the symptoms by having some restlessness, confusion, nausea, vomiting, warmness of the face. Sometimes the vision may be affected as well. This is the symptoms. The signs, usually the early sign detected by the anesthetist is hypertension to start with due to the volume overload, and later on the patient will start to have a hypotension and bradycardia.
Okay. How glycine is metabolized in the body?
So the glycine is metabolized mainly by the liver. 90% of it will be metabolized by the liver into glycolic acid, ammonia, and water, and 10% only will be metabolized in the kidney. The glycine has a direct, when there is a high level of glycine, it will have a direct toxic effect on the heart, so it will cause a myocardial suppression, and also it affects the nervous system, the brain by direct toxicity. It also contributes by producing water. It contributes to the volume overload and delusional hyponatremia, and also to stimulate the release of ethereal natriuretic peptide, which will cause natriuresis, which all contribute for more for the TUR syndrome.
Okay. Are there any measures to prevent TUR syndrome?
Yes, so the preventive measure is by assessment of the patient before the procedure, because we know some risk factor for TUR syndrome from the AUA cooperative study, which involved more than 4,000 patients. And they noticed that the main two risk factor for TUR syndrome is resection time more than 90 minutes, and the prostate volume more than 45 gram. So I will, in general, in my practice, I try to limit my resection into 60 minutes only, and I will try to use the bipolar diathermy as much as possible. I try to keep the irrigation fluid as low as possible, just enough to give me a good vision. And also, as I said, I will ask the anesthetist if he can to give the patient spinal, to do the procedure under spinal anesthesia, so the patient will be awake. I will check the preoperative serum sodium, make sure that the patient is not already having some degree of hyponatremia, review his medication, which may put him at risk of hyponatremia.
Okay. What is the risk of TUR syndrome in the contemporary studies?
So the risk of TUR syndrome is quite low. It's between 0.5 up to 2%. And according to this study, the AUA cooperative study, when the prostate volume is more than 45 gram, the risk is 1.5%, while when it is less than 45, it is 0.8. Also for the prostate volume, when the prostate volume is more than, when the resection time is more than 90 minutes, then the risk is around 2%. When it is less than 90, it is only 0.7%.
Okay, well done. And how do you treat TUR syndrome?
So for this patient, once I suspect that there is a TUR syndrome, I will ask anesthetist to take an urgent blood sample for the electrolyte, including sodium, kidney function, fluid blood count, clotting profile, group and save. And I will not wait until the result of the blood. I will start acting by, if the symptoms are mild and the patient hemodynamically stable, I will ask the anesthetist to give the patient furosemide 40 milligram, which will help in inducing water diuresis and relieve the volume overload and delusional hyponatremia. This can be repeated again. I will, regarding my role, I will try to control the bleeding as much as possible, keep the irrigation height low as low as possible, and try to finish the procedure, inserting the catheter, keep the patient on the minimum irrigation, involve the ITU team that the patient may need to go to ITU. After that, I will keep a close eye on his observation, a blood test, and take it from there.
Okay. When do you start the patient on hypertonic saline? What's indication?
So the hypertonic saline, the patient is not responding to the previous measures, mainly in the form of furosemide, and in spite of stopping finishing the procedure, the patient is still having a very low serum sodium, less than 115. Then I will consider giving the patient hypertonic saline, which will be given by my colleague in the HDU setting, and we need to correct it very slowly. So we need to correct 1 millimole per hour in order to avoid demyelination if we do a rapid correction of serum sodium.
Okay, well done. So we'll stop there. Any questions regarding the scenarios that we discussed today?
Nothing specifically, but when I attend the BAPU meeting, BAPU course, there was a discussion about a patient presented with testicular pain after 48 hours. What to do for them? Are you still taking them to theater for exploration or consider imaging? So I'm not sure if there is any guideline in this regard, or there is a different practice.
Exactly. So again, this was a discussion in the BAUS 5 course and also in one of the AGOR courses. So the current consensus is if the presentation is more than 48 hours, then we can wait for an urgent imaging to see, and most of the time these patients will have orchidectomy. So the main function or the main aim of doing imaging there is to rule out other pathologies so that we don't have to explore, because if it is a torsion and if it is more than 48 hours, the chance of orchidectomy is almost 100%.
That's what we do in our practice, but I was surprised that most of the pediatric surgeons, most of the pediatric urologists, they would recommend to take the patient to theater again, even after 48 hours.
Because it is based on a BJUI paper, and that was by Visser and colleagues. It was in 2003, and it's a nice paper, or it has got these box diagrams where it is nicely depicted how the testicular salvage rate will come down after 24 hours and especially after 48 hours. So the role of imaging is the late presentation of testicular torsion. I hope the exam, mostly for the exam, it should be straightforward scenario without controversies, and also if that should not be the mostly that will not be the primary scenario. It might be asked towards the end of the discussion as a question like as a shoot off question like what will be your approach if it is more than 48 hours. It all differs. You can say that if still I suspect torsion, then I will explore. You don't have to wait for because that is the safest answer always.
Yeah, definitely.
But practically, if it is more than 48 hours, then it's almost always orchidectomy. And if we have to rule out any other pathologies, it's always, and the main problem that we face practically is the difficulty in arranging ultrasound scan.
Yeah, it's almost impossible.
Exactly. So when you say that, you will still consider exploration that is safe for the exam purpose.
Yeah, thank you.
How I will spell it out is, for example, if the same question is asked, we can say that I will sit and discuss with the patient and explain the patient that there are only two possibilities. One is infection or inflammation, or the torsion. If it is infection or inflammation, exploring is not going to add anything. It's only like finding the diagnosis, which we can treat conservatively anyway. If it is a torsion, usually by 4 to 6 hours, the viability will come down, and after 24 hours, chances of viability is almost nil. By exploring, the only advantage is if the testis is completely dead, we can remove the testis. That may give a bit of a quick improvement of the patient, because rather than allowing the testis to slowly atrophy and get degenesis. And one other advantage is you can fix the other side. How you can space in the exam is, I will explain this to the patient, and if the patient is happy with exploration, I will explore. So that is the best answer even for the exam and also for the practice. Because after understanding the pros and cons, if the patient is quite particular in having exploration, I think it's better to do that, because there are some advantages like orchidectomy for non-viable testes and orchidopexy for the opposite 3-point fixation.
Okay.
Yeah,
I think
thank you very much.
That's
Very
brilliant.
comprehensive.
Yeah, because for our exam also, our decision was whenever there is a scrotal pathology, the best answer is exploration, because none of the scans are 100% sensitive or specific for the diagnosis and management thereafter.
Yeah, definitely.
Brilliant.
Since it is 48 hours, you can have scan as a backup. If the scan shows definitely there is no blood supply, then you will be much more stronger in which decision, which diagnosis even before exploration.
Exactly.
So nothing wrong in having the scan. And again, explain that documentation. A lot of times what happens is you do all these things in your day-to-day practice, but in the exam, you take it for granted and do not bring it out. We all know the importance of documentation. So in the exam, you need to believe as if the examiner doesn't know anything about you, and you need to prove him that you are a year one safe consultant in that 10 minutes. So don't shy saying about documentation, thinking that, oh, this is something everybody knows. I don't know, examiner will be expecting that, but that every small thing counts. Even I will say like, I understand the importance of documentation, especially in this patient. I also understand the medico-legal implications, and I will sit and discuss with the patient with the next of kin. So every word makes a sense.
Yeah.
I've seen a lot of trainees do this. They know this, but they don't bring it in the exam. That's the main thing.
Okay.
Yeah. And if I can ask another question, that a patient who is having intermittent pain in both testes, and we suspect that this could be an intermittent torsion, so we need to bring him for a prophylactic orchidopexy bilaterally. And my understanding is that this should be done on urgent basis, like in a matter of weeks rather than months.
So,
Yeah, those patients you can list it like a elective procedure, like of 3 to 4 days time, or the next available list. The best wording is again next available list, next available elective list. So by that you are ticking the box that you are doing this patient electively, number one, and also you are doing it in the next available list, so that the patient will not present again with a torsion-like symptoms in the midnight and wasting the A&E resources, etc. So next available elective list is a nice to notch.
Yeah, thank you.
A lot of times it may be unilateral, not necessarily bilateral intermittent pain. It may be even unilateral. And once we are convinced that it's an intermediate torsion, next available elective list is a nice wording.
Yeah, thank you very much.
So I think we have covered almost all of the emergencies now in the full discussions. We'll continue this and try to sharpen the skills during the 10-minute discussions. Okay.
Yeah, thank you very much. It was a wonderful session.
Thank you, Ren.
Very good.
Thank you, Mr. Severity.
Thank you, Anish. Again, a very in-detailed preparation and discussion. Thank you for the training, for the time, and the in-depth discussions. It is a very good revision source, not only for yourself and also for the colleagues for this batch and also the future batch. Thank you again, and wishing you all a very successful week ahead.
Yeah,
Bye.
thank you. Thank you very much. Thank you. Bye.
Thank you so much.
Bye.